Hi everyone. Because there are a lot of individual symptoms for post-traumatic stress disorder, I wanted to give you a chance to go over them before class. That way when we start on Friday, we can talk more specifically about what we know about this disorder and start thinking about how we differentiate it from other disorders and how we conceptualize thinking about different theoretical approaches to the disorder. So when we're talking about post-traumatic disorder, we are talking about a disorder that's characterized by symptoms that develop following exposure to one or more traumatic events. So unlike other disorders in the DSM, the disorders that are in the trauma and stressor-related disorders category include as one of their diagnostic criteria that an individual has been exposed to or experienced some kind of environmental situation. So for post-traumatic stress disorder specifically, our DSM criteria include that the person has been exposed to a traumatic event, and the DSM has some pretty specific criteria about what they classify as a traumatic event. So we call this Criterion A, and you might sometimes hear these described as Criterion A traumas. So we'll talk in a minute about what the DSM considers to be a traumatic experience. In addition, in response to this traumatic event exposure, the individual needs to develop a certain number and type of symptoms. So they need to develop at least one symptom of what's called intrusion, and we'll take a look at what those might include, a symptom of avoidance, 2 or more cognitive or mood symptoms, and 2 or more symptoms of changes to arousal or reactivity. So we'll take a look at all of these categories. In addition, the duration of these symptoms must last for at least 1 month, and these symptoms need to cause clinically significant distress or impairment. So on Friday, when we talk about the other disorders in this category, we'll talk about other diagnoses that might be appropriate if somebody doesn't meet that duration criterion. And we'll also talk about what diagnoses might be appropriate if a person is experiencing symptoms, but if the event that they're exposed to doesn't meet the DSM criteria for a Criterion A trauma. But for now, I want you to focus on symptoms that are consistent with post-traumatic stress disorder. So when the trauma the person is exposed to meets DSM criteria for the definition of a trauma, when the symptoms have been present for more than a month, and when these symptoms are causing significant distress or impairment. So let's start by talking about what the DSM considers a trauma exposure. So because this is Criterion A for post-traumatic stress disorder in the DSM, historically these have been referred to as Criterion A traumas. And what that means is that these are traumatic events or exposures that the DSM considers to rise to a level that we would consider them traumatic. So in the DSM-5, to meet Criterion A for trauma exposure, an individual needs to have been exposed to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. So the threat that experienced is a severe level of threat involving the threat of death or bodily harm, serious injury, or sexual violence. There's a number of ways that an individual can be exposed to these Criterion A traumas. The first is that a person can directly experience the traumatic event. So if they are threatened with death, if they experience a serious injury or other traumatic event themselves, that would meet Criterion A for trauma exposure. You can also meet Criterion A for trauma exposure by witnessing in person the event occurring to another person. So for example, witnessing a physical assault of another person would meet Criterion A for trauma exposure. So the person themselves does not need to be the victim of the traumatic event in order for them to experience that as a trauma. If the person does not witness it in person, learning that a trauma occurred to a close family member or friend may also qualify as trauma exposure if the case of actual or threatened death is violent or accidental. So what this excludes is situations like a natural or expected death. So if you don't witness a traumatic event occur directly, but if you learn that the trauma occurred to someone close to you, and if that traumatic event was violent or unexpected, that level of exposure could also be considered a trauma. And then finally, experiencing repeated or extreme exposure to aversive details of a traumatic event. So even if this traumatic event is not occurring to a person who is close to you, to a family member or a friend, this repeated or extreme exposure may be considered traumatic. It's important to note that in DSM-5, this explicitly does not apply to exposure through electronic media or television. So for example, watching repeated footage of a terrorist attack or watching media coverage of a natural disaster would not be considered a criterion A trauma exposure according to the DSM. There is one exception for this if that media-based exposure is work-related. So for example, people who work in court settings with children who are victims of sexual abuse may sometimes need to, as part of their work, watch repeated videotapes of children describing their experiences. So the DSM allows that kind of media exposure could be considered a criterion A trauma. But in the general population, media exposure to a traumatic event, even when it's repeated or extreme, does not meet criteria for a criterion A trauma. So across all of these, we have actual or threatened death, serious injury, or sexual violence, and we have different ways of meeting this criteria, whether it's applying to the person themselves, whether it's applying to other people that they have witnessed or learned about, and how they are experiencing this trauma, whether it's directly or whether they're gaining the information in other ways. So if a person has experienced a criterion A trauma, the additional symptoms of post-traumatic stress disorder have to do with their responses to that trauma and symptoms that they develop in response to that trauma exposure. And the first set of symptoms that characterize post-traumatic stress disorder are what we call intrusion symptoms. So in general, these are symptoms that are characterized by intrusive thoughts or memories or experiences that are related to the traumatic event that occur after the trauma exposure. So these can include recurrent and involuntary memories of the event. So when the person is maybe trying not to think about it, they might have memories coming into their mind that they can't control. This can also occur in dreams or nightmares. So these might be dreams or nightmares directly related to the event, or they might be dreams or nightmares with content related to the event that aren't directly about the event. Another intrusion symptom is commonly called flashbacks. So these are dissociative reactions where the person actually feels as though they are back in the event and it's occurring to them in real time. So it's a little bit even more intense than recurrent memories where the person is aware that they're no longer back in that event, but they're remembering what happened to them. During a flashback, a person is actually in an altered state of consciousness where they feel that they are actually back and re-experiencing the traumatic event. Another way that intrusive symptoms can manifest is through either psychological or physiological reactions to trauma cues. These can be internal trauma cues, so it might be something like a memory of the traumatic event, or it might be a physiological state that the person associates with the event. So for example, if they experienced pounding heart rate, or if they felt shaky during the traumatic event, they might experience symptoms if they have those physical symptoms at a later point in time. So for example, if their heart is pounding because they went for a run, that might be an internal cue that reminds them of the trauma. Or it might be external cues to the trauma. So anything in the environment that reminds them of the trauma. This might be places that they associate with the traumatic event. It might be people who look like people who were involved in the traumatic event. There can be olfactory cues, so smells that remind someone of the event. It might be sounds, any kind of internal or external cue that symbolizes or resembles an aspect of the traumatic event. So you can have intrusion symptoms that are characterized by psychological distress, so feeling very upset, having psychological distress, being very worried, or it might be a physiological reaction. It might be that they experience a panic attack or have some kind of other physical reaction when they're exposed to these internal or external cues. So all of these intrusion symptoms are characterized by intrusive, recurrent, involuntary ways in which the trauma continues to affect the individual after the traumatic event. And to meet criteria for PTSD, an individual needs to show at least one of these intrusion symptoms. In addition to the intrusion symptoms, a person needs to demonstrate at least one of these symptoms of avoidance. So in general, these avoidance symptoms are characterized by persistent avoidance of stimuli that are associated with the event. And this starts after the trauma occurs. So this might be the avoidance of memories or thoughts or feelings, either about the event or related to the event. So the person might try not to think about it. Or it might be avoidance of external cues. So they might avoid people associated with the event. They might avoid the place where the trauma occurred. They might avoid talking about it. They might avoid activities where the trauma might come up. They might avoid particular kinds of objects associated with the event. They might avoid situations that they associate with the trauma. Any kind of external cue or reminder that has the potential to lead to distressing memories or thoughts that are related to the event. So to meet criteria for PTSD, a person needs to demonstrate at least one of these avoidance symptoms. The next set of symptoms are the cognitive or mood symptoms of PTSD. So these are symptoms that are characterized either by changes to cognition or thought patterns, or changes to mood that occur after the experience of the traumatic event. And to meet criteria for PTSD, an individual needs to show at least two of these symptoms. So these cognitive symptoms might include an inability to remember an important element of the event. So often after a traumatic experience, people will report that they don't have a memory for either the full trauma or for some important part of that traumatic experience. And this is not due to a physical cause. So this is not, for example, related to a head injury that they sustained as part of the trauma. This is just that there is some element of that memory that they are not able to access. Another cognitive symptom would be persistent, exaggerated negative beliefs or expectations about the self or others of the world. You might recognize this looks a lot like Beck's negative cognitive triad. So an individual who develops negative beliefs about the world, things like the world is really dangerous, the world is terrible, terrible things are always happening to people, or beliefs about themselves. I deserve terrible things to happen to me, I'm worthless, I can't believe that I didn't do anything to prevent this. Those kinds of exaggerated or negative beliefs are characteristic cognitive symptoms of PTSD. Another cognitive symptom are persistent distorted cognitions about the event itself, particularly those that lead them to blame themselves or to blame others for this event in ways that are distorted. So for example, an individual might believe that they did something to bring the traumatic event upon themselves, or they might also have distorted cognitions about the consequences of the event. So for example, believing that they will never be a healthy or whole person, that they'll never be able to have a family or have good relationships, that they'll never be able to work because they've experienced this traumatic event. So those are some cognitive symptoms of PTSD. And we've also got some mood symptoms. So these can be characterized by a persistent negative emotional state. And that negative emotional state can really vary from person to person. So it might be persistent fear or anxiety, it might be characterized by horror, it might be persistent anger or irritability, it might be persistent guilt, it might be persistent shame, might be more depression, persistent sadness, and an individual might experience many of these negative emotional states. So persistent negative emotional changes in response to the trauma would be a mood symptom. You might also see what looks a lot like anhedonia, so markedly diminished interest in significant activities, people who stop engaging in activities that they used to be interested in, people who stop being interested or wanting to participate in activities that they used to find pleasurable. That would be another mood symptom. Another mood symptom that you see has to do specifically with interpersonal relationships. So people often describe a sense of detachment or estrangement from others. They'll say, I don't feel a sense of connection. I feel isolated from other people. And finally, people might describe an inability to experience positive emotions. So they might not have that persistent negative emotional state, but they might consistently feel neutral, or some people even describe it as feeling numb. They report that they're not able to experience a full range of emotions, that they're not experiencing necessarily negative emotional states, but that they're unable to experience pleasurable or positive emotional states. So to meet criteria for PTSD, an individual needs to have at least two of these cognitive or mood symptoms. And then finally, to meet criteria for PTSD, an individual needs to develop at least two symptoms of hyperarousal or hyperreactivity in response to the trauma. So these are characterized by an enhanced either emotional response or physiological response to threat or danger, or just kind of an elevated baseline level of arousal or reactivity. And there's a few ways that we can assess this. So one is that a person might engage in a high level of irritable behavior, or they might be very prone to angry outbursts with little provocation. Often this tends to be expressed as verbal or physical aggression, might be directed at people, it might be directed at objects. So you might see this hyperarousal in terms of kind of a baseline level of arousal, that it's much more irritable and angry than the person was before they experienced the trauma. Another way this hyperarousal might manifest is through reckless or self-destructive behavior. So drunk driving in a person who doesn't have a previous history of that, increased substance use. Combined with irritability, this might include repeatedly getting in physical altercations with other people. So engaging in reckless behavior or in behavior with a high probability for negative consequences for the individual. Another way that you can see this hyperarousal is through what's called hypervigilance. So this is a state of kind of increased awareness of the external environment and kind of a heightened attunement to threat. So for example, I had a patient that I was assessing who met criteria for post-traumatic stress disorder. He was a Vietnam vet, and his PTSD was related to combat exposure during the Vietnam War. And his symptom of hypervigilance was demonstrated when you would speak with him. Whenever he was in a room, he needed to position himself in the corner that was opposite the door, and he always wore sunglasses. And the reason that he wore sunglasses is because he was constantly scanning the room for potential threats. So when he didn't wear sunglasses, he knew that this tended to freak people out when he was interacting with them, because he didn't maintain eye contact, because he always felt that he needed to be scanning the room for potential threats. So he would position himself facing the door so that he could see any potential threat when it came into the room, and he was always monitoring his environment for any kind of dangerous or threatening situation. So that's a really clear example of hypervigilance, that his baseline level of arousal and reactivity is elevated compared to before he was exposed to the trauma. You can also see this manifested as an exaggerated startle response. Particularly in combat vets, you'll often see this, for example, in response to cars backfiring, any loud noise that might sound something like gunfire. You'll see a very exaggerated startle response and kind of a hyper reactivity of that fight or flight panic response to potential environmental threats. This can also manifest as problems with concentration. So you can imagine that if a person's cognitive resources are going towards scanning their environment and being aware of potential threats, that doesn't leave a lot of cognitive resources for other kinds of cognition. So they might experience problems with concentration, and they might also experience sleep disturbances, particularly just like we see in the anxiety disorders, difficulty falling asleep. So if you've got that hyperarousal during the day, it's going to be much more difficult to decrease that arousal to the point that's necessary to fall asleep. Or middle insomnia, difficulty staying asleep, that they're waking up frequently in the middle of the night, or maybe waking up in the middle of the night and having difficulty returning to sleep. So again, to meet criteria for PTSD, you need to have at least 2 of these symptoms of hyperarousal or reactivity. So to sum up, to meet criteria for full post-traumatic stress disorder, the traumatic event that the individual is exposed to has to meet those criterion A characteristics for a trauma. They need to have symptoms in all 4 of these domains. So they need to have 1 intrusion symptom, 1 avoidance symptom, 2 of the cognitive or mood symptoms, and 2 of the arousal or reactivity symptoms. These symptoms need to be present for at least a month, and these symptoms need to cause clinically significant distress or impairment. But given the number of symptoms that we've just described, you can imagine that the presentation of post-traumatic stress disorder can be very variable across individuals. So depending on the nature of the trauma that they were exposed to, and depending on the specific kinds of symptoms that they develop in response to this trauma, PTSD can look very, very different from person to person. So when we come back to class on Friday, we'll talk about how we distinguish PTSD from other disorders in this category, and then we'll start talking about our theoretical models that explain why some individuals develop these symptoms in response to trauma exposure.